Good afternoon, everyone. How are you? Hope you are doing good. I am Dr. Sultan Al Rashid. I am a diabetologist. I am also a pharmacologist. I am currently working as an assistant professor in the Department of Pharmacology, Savitha Medical College and Hospital. Today, I am going to discuss about one of the important topics, that is insulin dosing and regimens. Let's go into the topic. For most patients, insulin replacement therapy includes both long-acting insulin and a short-acting insulin. Long-acting insulin is called basal insulin and a short-acting insulin is called prandial insulin. The prandial insulin is given to provide postprandial needs. So in a mixed population of the patients with type 1 diabetes, what is the dose of the insulin? The dose of the insulin is usually 0.4 to 0.7 units per kg body weight per day. But in obese patients, those with type 2 diabetes and a pubertal adolescents, they require more amount of insulin. For example, the dose is about 1 to 2 units per kg per day because of the accompanying insulin resistance. These people have insulin resistance, so we have to increase the dose to 1 to 2 units per kg per day. The basal dose is usually 40 to 50% of the total daily dose, with the remainder as prandial or meal insulin. The insulin dose at the meal time should reflect the anticipated carbohydrate intake. A correction dose of the short-acting insulin should be added to the prandial insulin dose to allow the correction of the blood glucose. Administration of a single daily dose of long-acting insulin is not sufficient to achieve optimal glycemic control. So we have to give more complex regimens that include multiple injections of long-acting or short-acting insulin. They are needed to reach this goal. So in all patients, careful monitoring of therapeutic endpoints determines the insulin dose. So what are these therapeutic endpoints? So this approach is facilitated by self-monitoring of glucose, that is capillary or continuous glucose monitoring, measurements of A1C, and individualization of the patient's therapeutic regimen. So these are the goals of therapy for diabetes in non-pregnant adults. We should maintain this goal in a diabetic patient of non-pregnant adults. A1C, we should maintain less than 7%, and preprandial capillary blood glucose we should maintain below 130 in the range of 80 to 130 mg per deciliter. For peak postprandial capillary blood glucose, 1 to 2 hours of the meals, we should maintain less than 180 mg per deciliter. In the patients who have gastroparesis, that is delayed gastric emptying or loss of appetite, we should give injection of a short-acting analog postprandially. Based on the amount of food they actually consume, it may improve the glycemic control. Thank you so much for your kind attention, and kindly share my lectures to your friends.